Dear all, welcome to this NephroTube online lecture about the clinical practice guideline of KDIGO 2021 for the management of membranous nephropathy. As I'm always saying at the beginning of all my lectures, that all our lectures are present on our website nephrotube.com, and please join us on social media for more activities of NephroTube. And all our lectures are recorded in both Arabic and English languages on our YouTube channel NephroTube. Starting for membranous nephropathy, I will start by the presentation of membranous nephropathy. We all know that most of the cases of membranous nephropathy present with nephrotic syndrome. So nephrotic syndrome is present in 60 to 70% of the cases. Actually, as most of the nephrotic cases, blood pressure is normally or mildly elevated at presentation. And regarding the urine, there is proteinuria, which is not selective, and benign urine sediment, usually with absence of red blood cell casts. Okay, what about diagnosis and how to diagnose, or what is the new in the diagnosis of membranous nephropathy? First, we all know that membranous nephropathy equals subepithelial immune deposits of immunoglobulin and complement. Membranous nephropathy etiology may be primary or secondary. Let's talk about primary at first. How the deposits may reach the subepithelial space. There are three possibilities. The first possibility is the in situ immune complex formation, as an antibody will attack part of the podocyte. The second way is that the immune complex antigen antibody is formed in the circulation, then it is trapped in the subepithelial space. And the last point, the antigen is trapped first in the subepithelial space, followed by an attack of the antibody. Let's talk about the different native podocyte antigens that are discovered till now. The first was discovered was the phospholipase E2 receptor antibody, and it accounts for about 70% of primary cases of membranous nephropathy. In cases with membranous nephropathy, they found that this transmembrane protein antigen on the podocytes, thrombopoietin type 1 domain containing 7A, is responsible for about 10% of primary membranous nephropathy, which have negative anti-phospholipase E2 receptor antibody. And more recently, we have the NEL1, the nerve epidermal growth factor, and it is found in about 4 to 16% of phospholipase E2 receptor antibody, or THSD7 negative patients with membranous nephropathy. So the question now, is antiphospholipase A2 receptor antibody is specific or related only to primary nephropathy? The answer is no. Why? Because there is an evidence that some secondary cases may have antiphospholipase A2 receptor antibody positive. So the presence of antiphospholipase A2 receptor antibody is highly suggestive of membranous nephropathy, but it doesn't exclude the coexistence of the secondary cause. What make the antiphospholipase A2 receptor positivity is solid to diagnose primary membranous nephropathy is if you found the serum complement is normal, because it's mainly normal in primary cases, but it may be changed in secondary membranous nephropathy. So, in short, phospholipase A2 receptor antibody test is a good positive, but it is not a good negative marker for membranous nephropathy, because if it is present, so you have membranous nephropathy, it is usually primary, but maybe secondary. If it is negative, you cannot exclude the presence of membranous nephropathy, because there are other new antigens that antibodies are directed against them in the podocyte. How to detect phospholipase A2 receptor antibody in the serum? The best technique and the most sensitive technique is the Western blot, but it is not commercially available. The less sensitive, with intermediate sensitivity, is the immunofluorescence test. And finally, the ELISA assay, it is the least sensitive, and its cutoff value is of 14. Between 2 and 14, it is equivocal, and it's better to retest the patient with immunofluorescence if it is present. Okay, so we will measure phospholipase A2 receptor antibody. If it is absent in your patient of nephrotic syndrome, you have to do biopsy. If you have a patient with nephrotic syndrome and the phospholipase A2 receptor antibody are present. Check if the patient has normal kidney function, and you decided, as we will say later in this lecture, and you decided that you will not give him immunosuppression, then no need for biopsy. If the patient is on immunosuppressive therapy according to your decision, you have to consider doing a biopsy. And finally, you have to do biopsy if there is unusual clinical course or rapid decrease in GFR of the patient, if there is serological abnormalities indicating that there is a secondary cause, if you started immunosuppressive therapy and the patient is unresponsive to it with progressive kidney injury, or if the patient has persistent nephrotic syndrome despite disappearance of phospholipase A2 receptor antibodies. An important point that antiphospholipase A2 receptor antibodies may be absent at the beginning of the disease. So as we said, negative phospholipase A2 receptor doesn't exclude membranous nephropathy at all. And for sure, identification of the new antigens, as we said, there are other antigens as the NEL and the other antigen that may be positive in patients with negative antiphospholipase A2 receptor antibody. Membranous nephropathy may be secondary to a list of causes, and you have to exclude all these causes even if the patient has antiphospholipase A2 receptor antibody positive. So even you are suggesting that the patient has primary membranous nephropathy, you have to search and exclude secondary causes, as it is well mentioned and clearly mentioned in this statement in the KDIGO guideline. So you can do chest X-ray to exclude sarcoidosis, history of drug, ANA, full history and examination, virology, ultrasound of the kidney, screening for malignancies. Regarding malignancies, you can make simply chest X-ray or CT scan, look for iron deficiency and maybe occult blood in stool, breast and colon cancer screening, PSA in adult males aged more than 50 to 60 years. As it is shown in this slide, there are other new antigens in the podocytes that may appear with secondary causes. Look, the THSDA7, we know that from THSD7A, we know that from the beginning of the lecture, it may be positive in malignancies. Another antigen, the X1 and X2, may be positive in autoimmune disease. NEL1 may be positive with malignancy. So even the other new antigens may be present with secondary causes. That's why it is important to always exclude secondary causes in patients with membranous nephropathy. Important point regarding malignancy: if you screened your patient and you were 100% sure that there is malignancy and you didn't find it, you have to know that the malignancy may appear after 5 to 10 years from the diagnosis of membranous nephropathy. So if you are pretty sure that the patient is malignancy, after the management of membranous nephropathy or the diagnosis of membranous nephropathy, patient must be checked annually for the appearance of the malignancy. Okay, let's go through the treatment, and I will start by anticoagulant prophylaxis. And we stress on this point in patients with membranous nephropathy because we know that especially patients with membranous nephropathy have high risk of thromboembolic events. So at first, you will measure the serum albumin level, whatever the technique you are using. If the serum albumin is below 2 to 2.5 gram per deciliter, so this patient has high risk venous thromboembolism. If the serum albumin is between 2 to 3 gram per deciliter, ask yourself, or sorry, I will say it again, is the patient has serum albumin less than 3? If no, that means that the patient has serum albumin more than 3, so no prophylaxis is needed. If the patient's serum albumin is between 2 and 3, so you have to estimate arterial thromboembolic risk, and can be done by the Birmingham score, and you'll find the tools for all estimation for risks here that was mentioned by the KDIGO guideline. If the patient is at low risk for estimated arterial thromboembolic event risk, so no aspirin. If high risk, use aspirin. So what if the patient has high risk venous thromboembolism from the start? Assess bleeding risk here from these tools. For assess bleeding risk, if the patient is at high risk for bleeding, so it is enough to give aspirin. If the patient has low risk, so use warfarin or low molecular weight heparin plus aspirin. Okay, which is better, using warfarin or low molecular weight heparin plus aspirin? We all know that using warfarin in nephrotic patients, especially with low GFR, has multiple variability. So some physicians may prefer using warfarin and low molecular weight heparin, and once reach the targeted INR, they will stop the low molecular weight heparin. But a good alternative for that is to use low molecular weight heparin plus aspirin for about 3 months till the case or the patient be stabilized and has improvement of proteinuria. Then you can start warfarin at this point. Regarding treatment, you have to start by risk stratification. You have to put your patient in one of 4 categories. The first is low risk. When to say the patient has low risk membranous nephropathy, that if the patient has normal eGFR, proteinuria less than 3.5 gram per deciliter, and serum albumin more than 3 gram per deciliter. Or if the patient has normal eGFR with proteinuria less than 3.5 gram per deciliter, or a decrease more than 50% after 6 months of conservative therapy with ACE inhibitor and ARB. You will consider the patient as moderate risk if the patient has normal eGFR, but this time with proteinuria more than 3.5 gram per deciliter and no decrease more than 50% after 6 months of therapy, and not fulfilling high-risk criteria that I will mention. You consider the patient high risk if the GFR is low, with proteinuria more than 8 gram per deciliter for more than 6 months, or patient has the same criteria or moderate risk, normal GFR, proteinuria 3.5, no decrease in proteinuria, and one of these criteria. So moderate risk with one of these criteria is considered as a high risk. If the patient is not fulfilling these high risk criteria, the patient will be considered as moderate risk. What are these criteria? Serum albumin less than 2.5 gram per deciliter, anti-PLAR more than 50, urinary alpha microglobulin more than 40, urinary I immunoglobulin G more than 1, urinary beta-2 microglobulin more than 2.5, and selectivity index that is measured by clearance of IgG over clearance of serum albumin is more than 0.2. The patient is considered as a very high risk if there is life-threatening nephrotic syndrome or rapid deterioration of kidney function not otherwise explained. So now, after you stratified your patient into one category of these risk categories, you have to choose your immunosuppression. Choose immunosuppression according to the risk evaluation. If the patient has low risk membranous, so it's better to wait and see, except if the patient has any criteria of very high risk situation, you have to manage immediately. The patient is moderate risk, you can wait and see, or start rituximab or calcineurin inhibitor plus minus glucocorticoids. If high risk, you can start with rituximab or cyclophosphamide plus glucocorticoids or calcineurin inhibitors plus rituximab. If the patient is a very high risk, you have to start cyclophosphamide and glucocorticoid. The doses. If you will use cyclophosphamide, there are 2 regimens for the use of cyclophosphamide. The cyclic in cycles, you will start by methylprednisolone 1 gram intravenous for 3 consecutive days at the start of month 1, 3, and 5, and continue in month 1, 3, and 5 by oral prednisolone 0.5 milligram per kilogram per day. And in months 2, 4, and 6, you will give cyclophosphamide orally 2.5 milligram per day, 2.5 milligram per kilogram per day. This is a continuous cyclophosphamide regimen. You will give methylprednisolone as the first regimen, but you will give prednisone 0.5 milligram per kilogram per day every other day in months 1 to 6. Then you will taper it, and you will give the cyclophosphamide daily 1.5 milligram per kilogram per day for the 6 months. Regarding rituximab, we have two regimens. The first is to give 1 gram of rituximab at day 0 and day 15 of the disease, or give rituximab once weekly, maximum for 4 weeks. Regarding tacrolimus, it is given in 0.05 to 0.1 milligram per kilogram per day, targeting trough level of 3 to 8 and the duration for 12 months. Cyclosporin, 3 to 3.5 milligram per kilogram per day, targeting trough level of 125 to 225 nanogram per ml. Okay, so whatever you used, you have to measure phospholipase A2 receptor antibody at 6 months to check the response of your patient. Actually, more expert people with membranous nephropathy suggest to measure antiphospholipase A2 receptor antibody at month 3. Because in most patients, response occurs within 3 months after the start of the therapy. And if the patient has high antibody levels from the start, more than 150, you may measure it in intervals less than 3 months. So if the patient is in remission, antiphospholipase A2 receptor absent at 6 months, if you were using rituximab, no additional rituximab. If you were using cyclophosphamide plus glucocorticoids, stop them. If you were using calcineurin inhibitor plus minus prednisolone, calcineurin inhibitor plus minus prednisolone. An important point, if you are using ELISA for the detection of antiphospholipase A2 receptor antibody in the blood, the cutoff value to say that antipolar phospholipase A2 receptor antibody is negative is 2. This is the cut value, because we said between 2 and 14 it is considered as equivocal. And by the way, sometimes the serological remission precedes clinical remission by several months. So you'll find that the antiphospholipase A2 receptor antibodies may disappear before the nephrotic syndrome disappears. If phospholipase A2 receptor antibody is present at 6 months, you have to reconsider the therapy. If you are using rituximab, continue rituximab with 2 more doses. If you were using cyclophosphamide plus glucocorticoids, you have to stop cyclophosphamide plus glucocorticoid and add rituximab. If you were using CNI plus minus prednisolone, calcineurin inhibitor, add rituximab or cyclophosphamide plus glucocorticoid. If antiphospholipase A2 receptor antibody present but decreased to a low levels, actually this level is measured by immunofluorescence. So you cannot have this last category if you are using ELISA. But let's say that if you are using immunofluorescence and it has low level less than 50 antiphospholipase A2 receptor antibody, so if rituximab add 2 more doses, cyclophosphamide glucocorticoid, stop them and watch carefully. If on calcineurin inhibitor plus minus prednisolone, continuous calcineurin inhibitor for another 6 months and re-evaluate at 6 months. What about resistant cases? There is a large network of drugs in this algorithm. Whatever you started by, you have to re-evaluate your patient has EGFR stable or not. Then you have to select from this network that is designed by KDIGO guidelines the second line or the second treatment after the resistance for the first. But I want to say, to consider the patient resistant, you have to check compliance and efficacy monitored. So, for example, if you are using rituximab, you can check by B-cell response, anti-rituximab antibodies. You can also check by IgG levels, leukopenia for the cyclophosphamide, the trough level for the calcineurin inhibitor. What if the patient is resistant finally to rituximab, cyclophosphamide, and glucocorticoid? The patient must be referred to an expert center. Usually they will use bortezomib, anti-CD38 therapy, and ipilimumab, or higher doses of conventional immunosuppressive therapy. An important clinical point, if proteinuria persists despite that the serum albumin of the patient is normal and the phospholipase A2 receptor antibody is normal, this may reflect that the patient caught secondary FSGS, secondary to the membranous nephropathy. So not every proteinuria is due to activity of membranous nephropathy. So if the patient has normal serum albumin, normal serum antiphospholipase receptor antibody, non-nephrotic range proteinuria, this may be considered as secondary FSGS. And if you want to consider this proteinuria is due to membranous nephropathy activity, you have to redo the biopsy. If the patient has normal albumin, normal serum phosphate, normal antiphospholipase A2 receptor antibody, and the proteinuria, if you want to consider this is membranous nephropathy, not FSGS, you have to redo the biopsy. What about relapsing case? If you are using rituximab as an initial treatment, repeat rituximab. If you are using calcineurin inhibitor plus minus prednisone, you can use rituximab or calcineurin inhibitor plus rituximab plus minus rituximab. If you were using cyclophosphamide plus glucocorticoids, you can try them again, or add rituximab, or use calcineurin inhibitor plus rituximab. Finally, the lecture comes to an end. Thank you for watching, and see you in the next lecture.